So I'm going to start with the findings, of which the subjective findings, just about knowing the patient. For the info based on the question, we know that uh, her name is Gerlind, and she's of 70 years old. She's 70-year-old woman who moved recently after the death of her husband. She complains of slight shortness of breath when walking up the stairs and long distances. She voices no other complaints, and she has a history of atrial fibrillation, type 2 diabetes, COPD, mild heart failure, and is SPMI is 4 years ago. She lives alone and maintains good level of activity and self-care. She is maintained on metformin 500 milligram PO BID, glyburide 10 milligrams POQM, famotidine 20 milligram PO daily, digoxin 0.125 milligram POQAM, warfarin 5 milligrams POQAM, aspirin 81 milligram POQAM, and lastly furosemide 80 milligram. The objective findings, the objective part of the findings are the blood pressure is 169 over 88. She has a regular heartbeat. Her temperature is 99 degrees Fahrenheit. Her weight is 100 pounds. Her height is 5 inches, 5'2", and the PMI in the sixth intercostal space is 3 centimeters, distal to the mid-clavicular line. Her chest, there is a slight crackles at the end and left bases. The extremities, she's 1 to 2. ABI, which is negative. The HENT is slight heavy nicking, otherwise unremarkable. The medications that she is taking are metformin 500 milligrams twice a day, glyburide 10 milligrams every morning, famotidine 20 milligrams daily, digoxin 0.125 milligram POQM, metoprolol XL, which is 100 milligrams POQAM, furosemide 80 milligrams PO twice a day, aspirin 81 milligrams POQM, warfarin 5 milligrams POQM. The lab results came as there's a glucose level is 198 milligrams per DL, which is it is 11.3%. The serum creatine levels are 1.3 milligrams per DL. The serum digoxin level is 1.2 ng per ml. Moving on to the chest X-rays, there is some diffuse patchiness at the bases and also enlarged cardiac silhouette. There is decreased density of the vertebrae consistent with mild osteoporosis, the ECG, which is an NSR. Moving to the assessment, this is under the farm notes. I just finished with the findings. I will be moving to the assessment, then resolutions, and then lastly monitoring. So for the assessment, I found out that there is possible non-adherence and lack of knowledge about the medications. There is also mild to moderate heart failure as suggested by the pedal edema, DOE, and cardiomegaly on chest X-ray maintained on a beta blocker and is not currently prescribed an ACE inhibitor. There is also type 2 diabetes mellitus. The type 2 diabetes mellitus is not optimally controlled on metformin and glyburide. the ATC above goal of less than 7%. Not prescribed either an ACE inhibitor or an ARB for renal protective effects. Hypertension is not optimally controlled on metoprolol as suggested by increased BP and the elevated serum creatine and also the AV nicking. The renal and ophthalmic findings are suggestive of significant sustained hypertension. Repeated measurements will be necessary to confirm this assessment. About the atrial fibrillation, the rate control, the rate is currently under control with metoprolol and digoxin. There is no adjustment indicated. The anticoagulant, the INR, is above target range of 2 to 3 without clinical complications at this time. There is no cause could be identified, although a change in diet associated with recent life events is suspected. The next assessment is that there is possible moderate renal insufficiency as indicated by increased serum creatine. The renal doses adjustment may be necessary. SPMI on aspirin. There is possible dyslipidemia as suggested by history of MI and RO osteoporosis. The chest radiography is suggestive of osteoporosis. Her petite frame and age are consistent with the postmenopausal osteoporosis. The COPD, there is mild DOE. The mild DOE may suggest that the COPD is contributing to the heart failure symptoms. The COPD appears to be an untreated indication. About the adverse medication effects. Although metoprolol may be considered appropriate for both the post-MI and CHF indication and is a selective beta blocker, its beta blocking properties, which is usually higher doses, it may contribute to worsening COPD or CHF due to bronchoconstriction and also negative inotropic effects or even both. The medication without indication, which is the famotidine. On further questioning, the patient recalls being started on it while hospitalized for MI, and that happened 4 years ago. She was given a prescription for it when she left the hospital, and she has no complaints related to GAD or PUD. There is no need for famotidine can be identified. So that's all about the assessment, and moving on to the recommendations. First one being should be assess and reinforce adherence or rather concordance with recommended therapy. Should be educate on the purpose of each medication. There is about the mild to moderate heart failure. She should continue both the beta blockers and metoprolol and digoxin pending evaluation by the cardiology service to determine appropriateness. Suggest initiation of an ACE inhibitor at low doses and increasing furosemide to 100 milligrams PO twice a day until her return for the next week because of persistent pedal and pulmonary edema. There is no added dietary salt. She may consider adding spironolactone at the next visit. Both the type 2 diabetes mellitus, the recommendation for the medication she should suggest initiation of an ACE as above per current ADA guidelines. Suggest changing glyburide to 10 mg to glipizide XL 10 milligrams PO daily to improve control and enhance compliance. Um, she should also continue to follow blood glucose readings, and if indicated, may supplement glyburide with insulin lispro for elevated pre-meal PG based upon an estimated insulin sensitivity of 1 unit per 30 to 40 milligrams per DL. About the diet, she suggests 3 meals and a bedtime snack with no concentrated carbohydrate choices. She should limit CHO intake per meal to 60 grams, snacks 15 to 20 grams CHO, no added salt, AC and HS. About the hypertension, she suggests initiation of an ACE stated at low doses if repeated measurements confirm the diagnosis of hypertension. They may be titrated to maintain blood pressure control, which the blood pressure goal is 130 over 80 milligram mercury in patients with diabetes. Currently, the patient stage is 160 over 100 milligrams per kg. The atrial fibrillation, the rate control suggests continuing metoprolol and digoxin unless cardiology suggests otherwise. There is no adjustment indicated at this time. The anticoagulation INR, sorry about that, let's check. But the anticoagulation INR is above target range of 2 to 3. I recommend warfarin 2.5 milligrams today and then resume 5 milligrams PO daily. Dose to be adjusted is needed to maintain INR between 2 and 3. The renal insufficiency suggests hydration regimen and repeat serum creatine. There is no medication dosage adjustment indicated currently. SPMI recommend continuation of aspirin 81 milligrams POQM. I suggest initiation of ACEI, RBI, RB as noted above, and astatin, e.g. pravastatin, 10 milligrams PO at bedtime. She should also continue metoprolol if acceptable to cardiology. For the possible dyslipidemia, should be treated based upon lipid panel. Goal LDL is less than 100 milligrams per DL in patients with existing CAD or diabetes. This patient has both. So for the possible osteoporosis, if the X-ray scan indicates osteoporosis, should begin by phosphonates, e.g. aldehyde 70 milligrams PO weekly and calcium 1500 milligrams daily. The COPD also appears to be an untreated indication, suggesting initiation of ipratropium 2 puffs QID. The above adverse medication effects, as noted above, will weight cardiology opinion on the need for appropriateness of beta blocker and digoxin to manage CHF. The medication without indication suggests discontinuation of famotidine. So that's all for the resolution, for the recommendation. Moving to the monitoring part, of which this is the last part. The RTC should monitor the RTC in 1 week prior to RTC. The laboratory, the base electrolytes should also be monitored, which is the potassium, sodium, calcium, and magnesium levels in light of an opposed furosemide therapy of unknown duration and use of digoxin. The serum creatine to do a fasting lipid panel next week prior to RTC. the INR next week prior to the RTC, the DXS, and patient